Hi everyone. Let's discuss diabetes mellitus in pregnancy in today's sessions. So this diabetes mellitus in pregnancy, it is one of the most common endocrine disorder we encounter in the antenatal clinics. So when we say diabetes in pregnancy, it includes both women who already had diabetes before conception and those who develop high blood pressure for the first time during pregnancy. So now why is this so important? Because uncontrolled diabetes can affect both the mother and as well as the baby, leading to complications during pregnancy, delivery and even after the birth. So our goal should be early diagnosis, tight glycemic control and a healthy outcome for both the mother and as well as baby. So you will often see this as a routine screening topic in OPD. So it is very crucial to understand it clearly. So the common thing here is it can includes both pre-existing diabetes and the gestational diabetes mellitus. So you don't know whether the patient had before the history of diabetes or it's the first time. So it is very important to know the history also while diagnosing or treating the when the patient comes for the antenatal checkups. So let's move forward with the classification. We classify diabetes in pregnancy into two broad groups. First one, pre-gestational diabetes. That means the woman was already diabetic before pregnancy. It could be two, type 1 that is insulin dependent or type 2 diabetes mellitus which is insulin resistance type. Second thing is gestational diabetes mellitus. That is the second classification of diabetes mellitus in pregnancy, which is GDM, which is a glucose intolerance first detected during the pregnancy. So any degree of glucose intolerance first is detected during the pregnancy, then that is called as gestational diabetes mellitus. Sometimes we can't be sure whether it's truly new or just previously undiagnosed. But for management purpose, if it is diagnosed for the first time in pregnancy, we call this as a GDM or gestational diabetes mellitus. So this classification is very important because pre-gestational diabetes affect the baby early in the first trimester, while the gestational diabetes mellitus mostly affects the second and the third trimester. So you should be aware of the classification of diabetes mellitus in pregnancy. That is two types, pre-gestational and gestational diabetes mellitus. Next, let's see the pathophysiology. Pregnancy is called a diabetogenic state. Why? Because hormones from the placenta like human placental lactogen, progesterone, cortisol and prolactin, it act as an insulin antagonist. So they make the body resistant to insulin. Normally, the pancreas compensates by increasing the insulin secretion, but in some women, the pancreas can't keep up, so leading to hyperglycemia. So, here the core problem is insulin resistance, and that's why women who are already insulin resistant, like those with obesity or PCOS or PCOD and all, are more likely to develop gestational diabetes mellitus. So that is what the pathophysiology of diabetes mellitus in pregnancy. Moving on to the risk factors of GDM. So now let's see who are the high risk women. Obesity comes first. More fat means more insulin resistance. Second, a family history of diabetes. Third, previous macrosomic baby. So macrosomic baby makes more if the baby's weight is more than 4 kg, or if there is a history of stillbirth and all, that is also a risk factor. Then comes the PCOS or polycystic ovarian syndrome, advanced maternal age, that is above 30 years of age, and a certain ethnic groups, especially South Asians like us, have a higher genetic predisposition. So in these women, don't wait for 24 weeks. Start screening as early as the first trimester itself. So the key point here is early identification of high risk women. We can do the early intervention, so that early intervention will help us to prevent any kind of complication in future. So that is the risk factors of GDM. About the clinical features, most women with gestational diabetes mellitus are actually asymptomatic. So but sometimes they may present with the classical diabetic symptoms like polyuria, polydipsia, polyphagia, and sometimes there can be recurrent infections also. For example, candidiasis, so that is also present there, so present with this condition. And occasionally you may pick up gestational diabetes mellitus because of the excessive fetal growth, that is macrosomia. When the baby, it is like when it is more than 4 kg of baby fetal growth, then that is also can be seen in the clinical features. It is usually noticed on the ultrasound, so it's not always about the symptoms. Screening is the ideal key for such cases. Next, moving on to the investigations or screening and diagnosis. Screening and diagnosis, universal screening recommended between the 24 to 28 weeks of gestation for all pregnant women. So we use this one step 75 mg OGTT in process, which is a WHO criteria, where fasting greater than or equal to 92 mg per dl, 1 hour greater than or equal to 180 mg per dl, and 2 hour greater than or equal to 153 mg per dl. So if any one value is above the cutoff, we should be diagnosing this condition as a gestational diabetes mellitus. So remember, in high risk women like obese person or PCOS condition diagnosed, or whether if the patient is having a family history, we can do this test earlier in the first trimester. So if normal, repeat at 24 to 28 weeks. If not normal, you should be doing this test in the earlier as possible. So that is how we have to do the screening and diagnosis of GDM. Moving on to the investigation. So once we suspect or confirm diabetes in pregnancy or in the mother, whether it's a gestational diabetes mellitus, we should evaluate both the mother and as well as the baby. So for the mother, fasting and postprandial glucose, so that is FBS and PPBS, blood glucose level should be checked. And for HbA1c, you have to do for pre-gestational diabetes. So it is very useful in the such cases. For example, the pre-gestational diabetes, HbA1c is very important and very helpful also. Urine for ketones, and eye and renal evaluation if she is a non-diabetic. If the patient is having a history of diabetes, then eye and renal evaluation should be done. And so these things have to be done for the mother. And for the fetus, what you have to do, ultrasound for fetal growth, liquor and anomalies. So this should be done for the fetus. So our thing, we are focusing not only to the mother. With the mother, we are focusing both the mother and as well as the baby. So you have to do the investigations to check the health of the mother and also the fetus too. So this helps us to monitor for macrosomia or growth restriction depending on the control. So the ultrasound will help us to decide whether monitor for macrosomia conditions or growth, any kind of growth restriction or any anomalies depending on control. So these are the investigations we have to do, both to monitor the mother and fetus. Moving on to the maternal complications. So what are the complications whether the mother experience if she is diagnosed with the diabetes mellitus in pregnancy? First one is uncontrolled diabetes can cause several complications for the mother. Preeclampsia, polyhydramnios, recurrent urine tract infections, hypoglycemia, or preterm labor, ketoacidosis, in ketoacidosis in type 1 diabetes. And there can be increased rate of or risk of cesarean delivery due to a big baby, that is the macrosomia condition. So our aim is to prevent these through the early control and close follow-up. So these are the maternal complications you find if the patient is diagnosed or the mother is diagnosed with the gestational diabetes mellitus in pregnancy. Next is the complications we see in the fetus. So the baby can also be affected, especially if the maternal sugars remain high. So the common complications include macrosomia, as we discussed in the previous slides, when the baby is greater than 4 kg. So that is very difficult for the delivery, and there can be, it can also lead to shoulder dystocia conditions. So that is one of the fetal complication. Next is the congenital malformations, especially in the pre-gestational diabetes or due to early exposure and all. There can be congenital malformations in the fetus. Next, third is neonatal hypoglycemia. So, neonatal hypoglycemia after the birth, because the baby's pancreas has been producing high insulin. So, that is a complication. Next is respiratory distress syndrome. Last is stillbirth. If the sugar or the diabetes mellitus is remain uncontrolled, then stillbirth can also happen. So, maternal control of glucose is equal to fetal protection. That is the thing. So if we are able to control the glucose of the mother, that will help to protect the fetus from any other any future or further fetal complications. So that is the important fetal complication we will be seeing in the gestational diabetes mellitus condition. Now, how to manage? Before deciding OPD management, IPD management, we should be able to know differentiate it. So most GADM, gestational diabetes mellitus cases, can be managed on an OPD basis. The three pillars here are diet, exercise, and monitoring. So diet therapy, what you'll do, what you'll advise: small frequent meals which is high fiber, complex carbohydrates, and avoid any kind of refined sugars. Next comes the regular exercise. Light to moderate physical activity like brisk walking or prenatal yoga can be done, then advised. Or then next is self monitoring. So you have to advise to self monitor the glucose levels, fasting, and 2 hour post meal blood sugars. And if diet and exercise can't control it within the 2 weeks, then you have to start the pharmacotherapy. So in OPD, metformin is often used if not contraindicated, but insulin is preferred for tighter control, especially if the levels remains high. So it's very important to do a regular to advise and counsel the patient to have a regular antenatal visits and fetal growth scans, which is very mandatory in such conditions, so that it will helps to prevent any kind of complications in the pregnancies. So that is how we have to manage the condition on the OPD basis. IPD management, when do we have to admit the patient? When the patients have a poor glycemic control, complications like preeclampsia or ketoacidosis, when there is unstable sugars or the readings are very high. In such cases, you can admit the patient. In hospital, we prefer insulin therapy over any oral drugs. So we monitor sugars every 4 to 6 hours and adjust the insulin accordingly. And if ketoacidosis occurs, manage aggressively with IV insulin, fluids, and electrolytes, and also monitor the fetus closely. So our goal is to stabilize the mother before the delivery. So manage diabetic ketoacidosis promptly if it occurs. That is also very important. So this is how we have to treat the condition or manage the patient on the IPD basis. So hope you got an idea how to differentiate it and on what and all to do when the patients comes in the for treating the such condition in the IPD basis versus the OPD basis. Next is the intrapartum management. So how you will manage the condition in the intrapartum. So during the labor, we aim to keep maternal glucose between 70 to 120 mg per dl to avoid any neonatal hypoglycemia. Usually, we give glucose and insulin infusion, insulin to control sugar and glucose to prevent the hypoglycemia. So monitor the blood sugar every 1 to 2 hours during the labor. Continuous fetal monitoring is also very important. So if the baby is large or there are obstetric complications, cesarean section may be planned, but the principle here is control sugar, avoid any complications. So that have to be your goal in during the intrapartum management. Next is the postpartum management. So how you can manage the condition after delivery. So after delivery, the insulin requirements drop drastically because the placenta, which was producing the insulin antagonist hormone, is now out. So monitor sugars closely for 48 to 72 hours. Many women return to normal glucose levels after delivery. Encourage breastfeeding because it improves the glucose metabolism. And at 6 to 12 weeks postpartum, repeat an OGTT to see if the diabetes persists. That helps to detect women who may later develop type 2 diabetes. So this have to be done in the postpartum management. Next is the preconceptual counseling. So this part is very important for pre-gestational diabetes. Before planning pregnancy, advise the patients or advise the couples to have a tight glucose control for at least 3 months preconception, folic acid supplementation to reduce risk of neural tube defects, screen for complications like retinopathy, nephropathy and neuropathy and all, shift from oral agents to insulin before conception because some oral drugs are teratogenic. So this is what you have to do in the counseling session, and this ensures the better maternal and fetal outcomes. So this is what have to be done, and so this part is very important, especially the preconceptual counseling, very important for further advices you can give to the couples and as well as the mother. How to prevent it? Ask the patient it's like prevention comes before conception. It starts even before conception. Ask the patients to maintain a healthy weight, eat a balanced diet, stay physically active and avoid excessive sugar intake. For high-risk women, screen early and repeat test later. Education and lifestyle modifications, very important in a long way to prevent the gestational diabetes mellitus condition. So this is how we can prevent the condition of the gestational diabetes. Now we'll summarize what we have learned today. Diabetes in pregnancy includes both pre-gestation and gestational types. It results from the insulin resistance caused by placental hormones. Screening should be done between 24 to 28 weeks is very mandatory. Complications which affects both mother and baby we have discussed, and also the managements which includes diet, exercise, monitoring and insulin whenever required, and very important thing, early diagnosis and proper follow-up to ensure the healthy mother and the baby. So that's the key: early control, continuous monitoring and coordinated care. So this is what we have done today about the diabetes mellitus in pregnancy. Hope you got a clear idea regarding it. So let's wind up today's session. Thank you for patient listening and have a nice day.